It's about long-term outcome, and it's quite surprising how little data we have on something that is so famous and so expensive, and we spend so much on a procedure and we do not follow these patients up over longer periods, which was quite striking for me. These are my potential conflicts of interest. If we look at the survival of patients with ARDS in general, we can find this paper. It's quite old, but it conveys a simple truth about that these patients with acute respiratory failure, they tend to die over time after they are discharged from the hospital, and this mortality is quite significant, about 20% over 5 days after discharge. But what about their functional status? In terms of physical fitness, the survivors of ARDS are doing quite fine. As you can see, it's not far from predicted values. But when you look at mental functioning, this difference is quite significant. So they never fully recover. And this is just general population of ARDS survivors from the US and Canada. What about ECMO? ECMO are the most severe patients, often patients who are severely hypoxemic before they were put on ECMO. And as you can see, early reports from 2012, so 13-year-old, can see a small number of patients, approximately half of them, return to work after 1 year follow-up. So 50% are able to return to work. If you look at largest studies on ECMO, you can see that in fact survival differs over time. So there is something going on with survival depending on the capacity of the center and experience, and also the workload during the wave of the pandemic. The survival, short-term survival, was quite different. Survival in our part of Europe was significantly lower. We'll see it in the meta-analysis that we are preparing. As you can see, in Poland, this was the largest paper from Poland. Mortality was significantly larger than in Europe. However, it was slightly better than in Germany, for example. But in Poland, we had approximately 5 centers doing ECMO during COVID pandemic, and in Germany, they had 250. Okay, so what about long-term follow-up and long-term outcome? This was one of the best papers to date from Lancet Respiratory Medicine, led by Roberto Lorusso from Maastricht. And you can see that was over 1,200 patients. 600 of them survived, and they were followed up by phone. And you can see that the causes of death were quite similar to general ARDS population, with multi-organ failure rather than respiratory failure as a primary cause of death. But in the long-term outcome, you can see that back to full-time work, only a quarter of these patients were capable of returning to work fully. Another 13% were able to return to part-time work, and 5% required nursing home or long-term facilities. But 95% of them were alive after 5 months. So that was not so bad, and this so-called ECMO gap, this is the difference between ICU and hospital mortality, was not so high, because it's reported in some papers of being up to 20%, and here it was only 5%. And what were their main complaints after discharge from the hospital? As you can see, persistent dyspnea in over 1/3 of them. Also, Some of them required respiratory rehabilitation. Persistent cardiac syndromes was a broad term. Mainly they complained that something's going on with their heart, and the main complaint was tachyarrhythmia in most of them. And also persistent cognitive syndromes in 13%. Also, 6% of them still required oxygen supplementation. But persistent dyspnea seems to be the most characteristic of this group of patients. This was our follow-up. We're preparing a paper now on these 40 survivors. Most of them responded to our attempts of follow-up. 50% of them returned to work after 6 months. PTSD symptoms were prevalent in 25% of them. So very, very severe psychological consequences in these patients. But out of physical complaints, again, dyspnea was the most often. Other papers show more or less the same in terms of their functional status, not only ability to practice sport or returning to work, which was approximately also 50 to 60%. Also their sex drive, for example, was similar as before in only 50%. So this is significant disability. Another papers in which you can see the large proportion of post-traumatic stress disorder, but this seems to be not so very specific for ECMO. I think it's more specific for severe ICU, severe critical illness in general. But this is something that we should address at some point, because it seems that, at least in Poland, these patients get no help whatsoever. There is no psychological support for ICU survivors, unfortunately. And you can see that the problem is quite significant. Another study also in COVID-19 patients, you can see that the weakness was quite significant. Oh, it doesn't work. Does it work? It's not working. Okay, so muscle weakness in general was quite prevalent in these patients. So post-traumatic stress disorder, dyspnea, and weakness are quite striking complaints in these patients. And this is quite recent meta-analysis by Eddie Fan and his colleagues. You can see that they reviewed 32 papers, and this is the largest review to date. And it shows how little data we have, because you can see the number of patients included in these studies. You can see that in terms of physical fitness, ECMO was not significantly superior to mechanical ventilation. However, there was certainly no randomization in these studies, and these patients were put on ECMO as last resort because they were simply dying on mechanical ventilation. This same applies to their mental fitness. It was not different from mechanical ventilation, so they are not in worse condition, but not in the best condition either. And here you can also see the comparison between ECMO survivors in the first column, the ARDS survivors from the Heritage paper from 2003 that I showed you in the beginning, and the expected numbers, the normal values for Canadian population. And you can see that there is significant difference, especially in terms of emotional health and mental health. You can see, I cannot show it, the pointer doesn't work. So we know that there is significant burden in these patients, that they do not fully recover. However, we have surprisingly low amount of data. We are trying to do a follow-up of most our ECMO patients now, but these are still low numbers. Also, other applications of ECMO, such as ECPR, these patients, if they survive, they have quite good life quality, but again, emotional functioning and post-traumatic stress disorder are quite prevalent in this study. So they survive, but the quality of life is significantly different, and you can see that the survival is worse than in general population in these patients. So we should finish soon, and in general, what we can see in terms of post-traumatic stress disorder and their emotional functioning, you can see that there is a decrease in all these scores, especially in terms of depression and anxiety. However, again, the numbers that we have in long-term follow-up are really, really low. So this is a pity, because this is extremely expensive procedure. This is time-consuming, labor-consuming, costly, and we do not really know its long-term outcome. It's quite shocking. But this will be the topic of the next talk. The outcomes of critical illness, they do not only affect the patient, him or herself. It's also about his loved ones, his family, his society. So everybody is affected when these patients do not fully recover and they need physical or emotional support. And this applies also to, or in particular, to ECMO survivors. So in general, the quality of life in VV ECMO, at least, is somewhat similar to ARDS survivors. It's not so different from other ARDS survivors. Quality of life after ECPR and especially VA ECMO, so in circulatory support, is particularly impaired. And post-traumatic stress disorder, muscle strength, and depression are most frequent complaints in this population. However, approximately half of them are able to return to work full-time or part-time at least. And the problems that they face are similar to other ICU patients, and we seem to have no good solution for that, because at least in Poland there is no post-ICU care whatsoever. Thank you very much.